Good morning, and thanks for the GIS committee for inviting me for the 4th edition of GIS and for this complication session. I personally believe that we learn from complications more than what we learn from anything else. And I have no conflicts, and I chose the title based on one of the best-selling books that you can ever read. It's written by an Israeli-American psychologist and economist. It's called Thinking Fast and Slow. And this man is, his area of interest is how do we take decisions, whether we do it under stress or when we are resting, how the mind works. And one of his best quotes would be that the most effortful forms of slow thinking are the ones that we need to do it fast. And I and everyone, I think we all agree that PCI is done first in the mind, and then the hands would actualize what happens in the mind. So we go to our patient. He's a 58-year-old gentleman with diabetes, hypertension. He was admitted with pneumonia, lower respiratory tract infection, and decompensated heart failure. His troponin was rocketing high. His eGFR was 45. His ejection fraction was 35 to 40. And his ECG was actually non-localizing to a specific territory. And the same was the echo. And this is his angiogram. It looks not bad on the caudal projection, but in the cranial projection, you understand that there's no LAD. Diagonals are badly diseased. Distal circumflex is extensively diseased. There's lots of calcium. There's probably some left main disease. And it's more clear in the cranial projection. The LAD is gone. Distal circumflex disease everywhere. And his right coronary was probably sort of one of the remaining vessels, and it's supplying very faint collaterals to the LAD, and we can appreciate the extensive calcification in the proximal LAD. So the decision here is easy. He was referred to CABG, and the surgeon decided to accept him after the troponin comes down and after his pneumonia subsides. But I was surprised that the patient, his wife was a doctor, and his treating cardiologist, they all insistently refused bypass. And in the beginning, I also refused PCI. So I discharged him, giving him a chance to recover, giving him a chance to think, but he didn't give us the chance. He came 1 week later with another episode of acute pulmonary edema. He refused surgery. I tried to explain all the risks on earth, but he agreed to all the risks and he agreed on staging. So thinking here, we had time to think what to do. We thought that the LAD is the target. As Dr. Sianis mentioned, it's always the LAD. And we had to assess the left main, then possibly do the circumflex, be ready for an atherectomy, and it's probably a CTO, so we need a bilateral access. He was given aspirin and ticagrelor. We used a long sheath and a 7 French guide to get the best support. We had our microcatheter and the wire. And initially, we were not sure whether we were in the true lumen or not, but the wire went into the septal perforators, so we knew we were on the right track. Then the Gaia second made its way into the distal LAD. In the beginning, we were not sure. In the mid-segment, we know we are in the LAD distally. We were not sure that it's the LAD. We confirmed by the retrograde injection that we are in the distal LAD. We exchanged for a workhorse, and we were planning for rotablation. But just before we started the ablation, something bad was happening in the proximal LAD. We were not sure this is a dissection or a thrombus. His ACT was in the target range, so we backed off from ablation, and we decided to go for a balloon. Unfortunately, the balloon wouldn't cross, and you see the dog boning in the proximal LAD. And the picture was slightly better. And so we decided to go on for ablation. And we thought it's going to be an easy ablation, but it wasn't. The lesion was really tough. It took us 5 runs until we managed to cross with the burr and modify the plaque. And we tried all the maneuvers. We tried pecking. We tried slow advancing until we managed to do it after 5 runs. But what happened after that is the sky fell on the earth. The patient crashed into asystole. We managed to remove the wire, the rota burr quickly and inflate a balloon. Our thought process at that time is that we lost the LAD and we lost everything else in the left system. There's slow flow everywhere. So what to do at this stage? We already ballooned the vessel. We had some flow in the LAD, but the patient is not recovering. So we thought, let's go and open the diagonals. So we went in with a balloon, we inflated the diagonal, and with barely any improvement. He's still in brady asystole. CPR was ongoing. We removed the guide from the right coronary artery. We placed an intra-aortic balloon pump to help boost the circulation. Now we have the circumflex open, a trickle of flow in the LAD and in the ramus, but still the patient is in asystole. So if it's not the LAD and one diagonal is open and it's not enough, so that's the thinking. So perhaps the second diagonal would help. So we went in, we crossed into the second diagonal while doing CPR, and then we started to see some improvement. So it was the big diagonal that resulted in the catastrophe. So we went and dilated, but he still didn't recover. So we thought, if ballooning alone is not enough, then let's go and save the diagonal. Then the technician gave me the stent 3028, and you see it crossed wonderfully, and we regained the patient. Now we're starting to have some circulation, but we lost the LAD in the way, so we got asystole again. We had to do the POT and recross while they are doing the CPR, and then we managed to open the LAD. We opened the strut in the stent, and then we crossed with the stent. We had a form of culotte, and we tried to avoid the left main, ending with kissing balloons, and we regained him back. And this whole drama took 10 and 15 minutes. At that time, we decided to stop because we started having massive GIT bleeding on table. But we had the patient alive, and he responded marvelously. He didn't stay in the hospital for a long time. He didn't require dialysis. He just had an endoscopy that showed a large gastric ulcer, and I saw the colleague, my surgeon, happily wondering what would have done if he went into cardiopulmonary bypass with a large bleeding ulcer. He was discharged home, and we agreed that we need a second procedure to assess the left main, the bifurcation, and the right coronary artery. This time we went minimalistic. We had to think what to do, the left main, circumflex, RCA. We need to be mindful about contrast, about GIT bleeding. So I decided that we start by the RCA. And physiologically, the RCA, although angiographically didn't look bad, physiologically it was really significant. The IFR was 0.79. So we decided to balloon. We used high pressure balloons. We got a final result. So we ended up with a drug-coated balloon. So the right coronary was fine. Then we used the guiding. We went into the left coronary. The stents are great, but there's a significant left main that we didn't appreciate in the first angiography, probably because of the diffuse disease in his vessels. We did an IVUS. The calcium in the left main was not 360 degrees, so we decided to use a high pressure balloon. We deployed the stent, we did the POT, and that's the final IVUS result with an MSA of 12 millimeters mercury. And this is the final result that we got. I know there's some residual lesion in the diagonal, and there's the distal circumflex. We can argue, should we treat these, or are they prognostically important or not? But we were happy that this procedure was done 11 months ago. The patient is asymptomatic with a decent ejection fraction and a decent eGFR. So what did I personally learn from this case? Counseling is not easy. I kept thinking to myself, why should I take him to PCI if he doesn't want to do bypass? And high-risk PCI is not safer than CABG. And be ready to work under CPR, to cross lesions under CPR. Be ready to think under pressure. And very importantly, the vessel that has been occluded the last needs to be probably opened the first. Thank you so much.
Thank you.